sir, and my fellow colleagues. Today's topic of discussion will be mesenteric arterial diseases. Coming to introduction, mesenteric ischemia basically occurs when the perfusion fails to meet the normal metabolic requirements of visceral organs. Basically, mesenteric ischemia is divided into acute and chronic based on the duration. That is, acute is seen when the duration is less than within hours to days, and whereas in chronic it is from weeks to months. The most common cause for acute mesenteric ischemia is basically of two types. That is the uh, embolic and the thrombus. And under chronic, you have atherosclerosis. Coming to anatomy, basically the primitive dorsal aorta is forms the abdominal aorta, and the primitive ventral aorta forms the ventral segments of the arteries. These ventral segmental arteries normally disappears by fourth week of gestation. Only the 10th, 13th, and 21st branches persist to develop the common celiac artery, the superior mesenteric artery, and the inferior mesenteric artery, respectively. Coming to celiac artery is basically situated around the L1 segment, and it is surrounded by superiorly by the median arcuate ligament and inferiorly by the superior border of the pancreas. The three main branches of the celiac artery are the left gastric artery, the splenic artery, and the common hepatic artery. There are three. The most common variations seen within the celiac artery branches are that the common hepatic artery and its branches arise from superior mesenteric artery or directly from the aorta. Superior mesenteric artery arises few centimeters quarter to the celiac trunk. This is less acute and downsloped angle than the celiac artery. The first most important branch of superior mesenteric artery is the inferior pancreaticoduodenal artery, and second important branch is the middle colic artery. I'll just explain you about the anatomy of the superior mesenteric artery. Basically, the territory of the SMA ends at the distal portion of the transverse colon, and that of the IMA begins in the region of the splenic flexure. A large collateral vessels, the marginal artery uh, connects these to circulation and forms a continuous arcade along the mesenteric border of the colon. The superior mesenteric artery supplies the entire small wall, giving of 12 to 20 jejunal and ileal branches to the left, and up to three main colic branches to the right. In this, the ileocolic branch is the most consistent of these branches. The collateral circulation in this area of the splenic flexure is the most inconsistent of the entire colon and is referred to as the watershed area and is most susceptible to the ischemia in the presence of any hypotension. The inferior mesenteric artery is about 3 to 4 centimeters cephalate to the aortic bifurcation, and it is situated left to the left of the midline and is situated around at L3 segment. The branches are left colic artery and the sigmoidal branches. The sigmoidal branches further divides into left and right superior rectal arteries. There's one more. There's a specific kind of artery known as the mesenteric artery, also known as the arc of Riolan. The arc of Riolan is nothing but a collateral artery that directly connects the proximal SMA and the proximal IMA, and it serves as a vital conduit when either of the arteries is occluded. It is also known as the main ring mesenteric artery and is highly variable in size. The flow can be forward in cases of IMA stenosis or retrograde in case of SMA stenosis, depending upon the site of obstruction. Coming to physiology, normal intestinal function and nutrient absorption rely on adequate perfusion and oxygenation to the microvascular splanchnic circulation. The main three autoregulatory mechanisms that involve in the blood supply to the intestines are the extrinsic factors, hormonal factors, and the renin-angiotensin feedback mechanisms. Coming to extrinsic factors, these include sympathetic efferent nerves in the prevertebral celiac and the mesenteric ganglion, which initiate and stimuli for arterial vasoconstriction. Coming to hormonal factors, you have also is that the extrinsic regulation of spastic blood vessels. The renin-angiotensin feedback mechanism also causes mesenteric vasoconstriction through the direct action of angiotensin II during hypovolemic states. The intrinsic regulation also plays a major role uh, through mainly two types: the metabolic pathway and the myogenic pathway. In case of the metabolic pathway, the mucosal ischemia prompts the release of metabolic byproducts, causing vasodilatation in arterial smooth muscles and preferentially shunting increased blood flow to the intestinal mucosa. In case of myogenic pathway, which dominates the regulation of blood flow in the small intestine, abrupt decrease in the perfusion pressures are sensed by arteriolar baroreceptors, which respond by decreasing arterial wall tension to maintain blood flow. Together, these mechanisms maintain mucosal perfusion and integrity during periods of relative ischemia. Because the mesenteric circulation has a rich collateral network, most patients only develop symptoms only when at least two of the three mesenteric arteries are severely narrowed or occluded. Coming to pathophysiology, first I'll be speaking about chronic mesenteric ischemia. Here, the most common cause of chronic mesenteric ischemia is atherosclerosis. Here, the patient also has a history of smoking, hypertension, hyperlipidemia, and evidence of atherosclerotic diseases in other vascular beds. It is also associated with vasculitis and other inflammatory conditions. Median arcuate ligament syndrome caused by compression of celiac artery by median arcuate ligament is also seen. In case of acute mesenteric ischemia, here you have four types. You have the arterial embolism, arterial thrombosis, nomi, and the mesenteric venous thrombosis. Coming to arterial embolism, the most common cause of acute mesenteric ischemia. It is seen in 40 to 50% of the cases, and the source is mainly from the intracardiac mural thrombus. And it is also seen in cases of atrial tachyarrhythmias, myocardial infarction, cardiomyopathy, structural heart defects. Superior mesenteric artery is the most common final destination for mesenteric emboli. It is mainly because of its size and decreased angle of takeoff. The emboli tends to lodge usually distal to the middle colic artery. Here, the angiographic hallmark of this, in case of superior mesenteric artery emboli, is that there's abrupt cutoff just beyond the origin of the middle colic artery. In cases of arterial thrombosis, this is the second most common cause of acute mesenteric ischemia. Here, it causes about 20 to 35% of the cases are seen. And the most common findings is that pre-existing atherosclerotic plaque involving all the visceral vessels are also seen. Here, the affected segment is from the origin of the level of the aorta. And two most important points to remember here is the mortality and the extent of the bowel if affected is more in cases of arterial thrombosis than in arterial emboli. Now coming to non-occlusive mesenteric ischemia, here impaired intestinal perfusion is in the absence of any thromboembolic occlusion. Here around 5 to 15% of the cases are seen, and mainly occurs due to low flow states, which is exaggerated by the presence of any intestinal atherosclerotic diseases. It is most common is secondary due to cardiac diseases, congestive heart failures, and atrial fibrillations. Here the main reason is due to spastic vasoconstriction, so that there's blood supply to the other vital organs. Other risk factors are old age, hypovolemia, systemic vasoconstriction, vasoactive drugs, aortic insufficiency, cardiopulmonary bypass, abdominal compartment syndrome, and liver failure. Nomi is also most commonly seen in patients who undergo regular maintenance hemodialysis, and it is also seen in patients with end-stage renal disease who are on frequent erythropoietin injections. This causes increase in red cell mass and hyperviscosity, leading to Nomi. Coming to mesenteric venous thrombosis, it is seen in about 5 to 15% of the cases, and it is usually limited to the superior mesenteric vein. Here, inferior mesenteric vein is often spared. It is basically of two types, primary and the secondary. Secondary is due to any underlying causes, uh, uh, and it constitutes about 90% of the cases. Conditions associated with MVT are grouped into mainly three categories. Here you have direct injury, which includes abdominal surgeries, trauma, and local inflammation. And second is uh, local venous stasis or congestion. In this, the splanchnic venous stasis may occur in the case of increased abdominal pressure, obesity, and with intraoperative manipulation of the mesenteric vessels. And third is thrombophilia, like inherited or acquired hypercoagulable diseases. The extent of bowel ischemia basically depends on two main types. That is the degree of venous involvement and the presence of collateral vessels. Here, one more important thing is the transition from normal to ischemic intestine is slower when compared to the arterial occlusive disorders. The mortality in MVT is about 20 to 50%. Clinical presentation, patients with acute mesenteric ischemia, most common symptom is sudden onset of severe abdominal pain. They also come with complaints of nausea, vomiting, diarrhea, emptying symptoms, distension of abdomen, abdominal guarding, tenderness, melena. Here, patients mainly present with pain that is out of proportion to the clinical findings. Initially, patients will have increased bowel sounds, but due to the ischemia, later on, bowel sounds will be reduced, and patients will also develop oliguria, dehydration, confusion, tachycardia, and may also present in shock. Coming to chronic mesenteric ischemia, here two main things that help us in diagnosis of chronic mesenteric ischemia is the postprandial abdominal pain, and patient are um, present with excessive weight loss. They're cachectic. The pain abdomen basically is dull lacking pain, and it is mid-epigastric and mainly occurs 5 to 15 to 45 minutes after the ingestion of food. Changes in bowel habits and nausea and vomiting are less common when compared to the acute mesenteric ischemia. Chronic mesenteric ischemia most commonly seen in elderly women. Here, history of smoking and atherosclerosis is also present. Guarding and rebound tenderness are usually absent in cases of chronic mesenteric ischemia. Coming to diagnostic evaluation, uh, Doppler ultrasound scanning, color Doppler scanning is used to assess the flow velocities and resistance index in splanchnic arteries. We can also make out transmural hemorrhage, inflammation, and necrotic thickening of the bowel wall. The two main drawbacks of ultrasound is one, it is operator dependent, and other patient factors such as obesity, increased bowel gas, variation in local anatomy, and variation with respiration also decreases its usability in diagnosing mesenteric ischemia. There are two criteria where we can diagnose mesenteric ischemia based on ultrasound. One was proposed by Monito and colleagues. Here, which it states that lack of flow or peak systolic velocity (PSV) in the SMA of greater than 275 centimeters per second, or no flow or a PSV of greater than 200 centimeters per second in the celiac trunk was a reliable indicator for 70% of the greater angiographic stenosis. In this, according to this study, the sensitivity for SMA was 92% and celiac artery was 87%. The inferior mesenteric artery cannot be assessed since it is difficult to visualize in cases of while using a Doppler. The Bosox criteria, in this, it is based on 50% arterial stenosis. For SMA, the end diastolic flow velocity of 45 centimeters per second or higher, and the sensitivity is 90% and specificity is 91%. For celiac artery, the reversal of blood flow in the hepatic and the splenic arteries was 100% predictive of stenosis. An end diastolic velocity of more than 55 centimeters per second or no flow signal had the best overall accuracy. Here it shows the sensitivity is 93% and specificity was 94%. This is a mesenteric Doppler ultrasound which shows you normal and abnormal waveform patterns during fasting states. Coming to CT, It is an accurate, non-invasive imaging modality for diagnosing mesenteric ischemia. The sensitivity while using CT is 93% and specificity is 96%. The advantages of a conventional angiogram, it is easier and speed of the procedure and rapid infusion of contrast agent through peripheral line and simultaneous imaging of arteries, veins, and visceral organs. The main radiological findings to diagnose mesenteric ischemia is increased thickening of the bowel wall and increased dilatation of the bowel wall. You may also find pneumatosis intestinalis, portal venous air, and which includes a delayed venous phase in addition to an arterial phase, has been used in diagnosis of acute mesenteric ischemia, since it enables detection not only of arterial occlusion but also mesenteric vein thrombosis and improves the ability to detect changes in the bowel wall as well. The main disadvantages of CT is radiation and risk of contrast nephropathy, hypersensitive reaction to contrast. Coming to magnetic resonance angiography, although it may take longer for the procedure, it avoids radiation to the patient, and it can also be used in patients where there's hypersensitivity to contrast agents. CT angiography has a superior better visual painting by this effect, giving it a distinct advantage over MR. This image and occlusion of the celiac trunk as well as lateral views are used for the identification of the aorta, celiac trunk, SMA, and IMA. Basically, the two main views are APA and lateral. For identifying of celiac trunk and SMA, lateral views are most commonly used. For celiac and SMA, lateral views are used, and for IMA, we use a 15-degree angle of left oblique view. And other things are gastric tonometry or measurement of PCO2 levels in gastric or jejunal or colonic mucosa. These are useful adjuvants for diagnosis of mesenteric ischemia. Coming to treatment, for acute and chronic mesenteric ischemia, we have basically medical, endovascular, and surgical. Coming to medical end of management, we need to give aggressive fluid resuscitation, restoration of adequate urine output, and correction of electrolyte imbalance. Basically, these patients mainly present with hyperkalemia and hyperphosphatemia, and they also have increased lactates, significant metabolic acidosis, and these patients has to be put on broad spectrum antibiotics mainly to concentrate on the gram-negative and anaerobic bacteria. Medical management is usually not alone efficient in treatment of symptomatic mesenteric ischemia, which has to be adjuvanted with surgical or endovascular procedures. Basically, once we do a mesenteric stenting, until and unless it is contraindicated, a loading dose of 300 clopidogrel has to be given, and maintenance with a low dose aspirin and statins has to be given. Injection of papaverine can also be given intraarterially after selective catheterization for vasodilatation. Coming to endovascular procedures, the main indication is revascularization is indicated in all patients with symptoms of
Arjun. Arjun.